Good morning, everyone. It is truly a pleasure to be able to introduce Dr. Maria Trent, a wonderful colleague in adolescent medicine, brilliant researcher, clinician, educator, mentor, and leader. And lucky us, this is the second time in 3 years that we've been able to get her really on her busy schedule to come and join us. Dr. Trent is professor of pediatrics, American health, and nursing at Johns Hopkins University. She is chief of the Division of Adolescent Medicine and Young Adults at Johns Hopkins University School of Medicine. She's an independent research scientist and serves as the principal or key investigator on multiple research projects and training grants funded by the NIH and other funding sources. A significant focus of Dr. Trent's research and clinical interest has been on reducing adolescent and young adult sexual and reproductive health disparities. Dr. Trent is the immediate past president for the Society of Adolescent Health and Medicine, has served 2 terms as chair of the executive committee for the section of adolescent health within the Academy of Pediatrics, and currently she serves on the board of directors for the American Sexual Health Association. While chair of SOAH, she led the development of the AAP policy statement, the impact of racism on children and adolescents. She is a sought after speaker, author of research articles, editorials, book chapters, and patient directed media in child and adolescent health. And of course, not surprisingly, professional organizations and lay press have recognized Dr. Trent for her work, and she has emerged as an important voice and a forceful advocate for the health and well-being of young people and those who care for them. Join me in welcoming Dr. Maria Trent.
Good morning, everyone. Thank you for inviting me back. I so love being a part of this group. I wish I was there in person today. I will share with you, I will ask you to forgive me if you happen to hear a dog bark or an adolescent walk behind me. I am at home today. We're having a snowstorm, so hopefully we'll make it through just fine, but I wanted to give you that disclosure in advance. So my objectives today are really to describe the levels of racism and emergence of racism as a key determinant of health, to discuss the potential impacts of discrimination on children and families, to think about how we can incorporate a cultural competency, a raising resistance approach to anticipatory guidance, and scientific innovation as key strategies for reducing health disparities. So my disclosure, I do have some disclosures related to my research, which I'm not discussing today. So there are no financial disclosures related to this talk. What I will say, though, is that my disclosure is that I grew up in the rural South in North Carolina. It's one of the most beautiful places in America. It's in Perquimans County. Perquimans meaning the land of beautiful women. And yet this is the image that anyone would see every day coming into my town. And so I have had a long history of seeing racism, of experiencing racism, and of navigating spaces in which racism still lives. I think my challenge is that I have recently been listening to Isabel Wilkerson's cast, and after having written the policy statement, which was a process in of itself. And what I'll say is that there's this point in the narrative where she talks about that moment where you have to tell your children that in the United States there is a caste system and that you are not in the top caste, and how it eats away at the parent, or how the parent tries to avoid that moment. And then we realize we have to tell them so that we can protect them. And so as the parent now raising 2 adolescents on my own, since my husband passed away, it's really critical for me to think about ways that I can protect them and keep them safe, and how I need all of us to participate in that. So my premise is really that children and adolescents are the message that we send to a time that we cannot see, and that we need to act swiftly to ensure that the message we send is a decisive one. In the United States, over the last year and a half, we have had so many incidents that relate to racism that is disturbing. I have been particularly moved by these cases of young people and older people who have been murdered through interactions with police, so much so that society is calling upon our civil rights leaders, Martin Luther King, Malcolm X, John Lewis. The reality, though, is that King and X were both assassinated for their efforts to help change society. And I'm not sure what John Lewis would think if he could see us in this moment. Because just recently, this is the scene in our nation's capital, that we had to have the National Guard present to ensure that there's a peaceful transition of power. And as someone who lives in this region, spends a lot of time in Washington, D.C., the reality is that it was really quite frightening to watch it unfold locally. I am reminded, though, at times, that I will confess that there are times that I'm just tired of racism. And I think back to the case of Tamir Rice, who should be on the left side of your screen, who was killed by police while holding a toy gun in a park in Cleveland. And how eerily similar he looks to Emmett Till, who was killed, who was lynched in 1941. And it's a really, these two, 112, 114, they're really sort of the group that I'm really interested in protecting, not just because I have an emerging 13-year-old, but also because it's just tragic how it keeps recurring. I think the case of the 14-year-old boy who was falsely accused by a woman in New York City, who was protected by his father, I think was a really profound case of how we're not seeing adolescents as children, not seeing them as adolescents, and not protecting them, and how important it is for parents to engage in these processes around protection of their children. And then when we think about general safety, we have not been able, despite young people protesting, telling us that they want greater safety, been able to protect our children from firearms deaths. The reality is when we look at non-Hispanic Black children, we see that their rates of death are sixfold, and for Hispanic or Latino, almost threefold. And then COVID-19 has thrown something utterly different into the mix. And we see this endemic of disease and racism coming together in a really, really harsh way on our society. And so I am with Dr. Mary Frances Berry in that I believe that every generation has to make a dent in the wall of injustice. And so I've been trying to do that through partnership with other people. This image, but young people are showing us the way. So this is an image that was taken by a young person in my community of the protests in Baltimore. They are seeing what's happening, and I think we have to see it and write about it and think about it and really advocate for change. What's even more exciting is when young people who aren't necessarily, for example, living in a Black body or experiencing a Black life say, we are not going to be divided from you and we're going to stand with you. I want you to remember this because I'm going to show you something later at the end about how you can do that in everyday life. And COVID also has had these impacts on our young people's outcomes. And so I think that's the other challenge that we're going to have as a society is if there are already disparities facing young people from certain communities based on race, ethnicity, how do we ensure that we move into a post-pandemic phase that's really thoughtful in terms of how we address disparities in education and developmental outcomes? So I've decided that I'm not also accepting things that I can't, that I'm no longer accepting things that I can't change. I'm just going to try to change the things that I can accept. And so when I think about the United States, it's important that I think about it this way because the United States is projected to become more racially and ethnically diverse in the coming years. It's already that way. Of babies born in the United States every day, they're just more and more diverse. And yet in the United States, globally, for all young people, we spend less than other countries with our wealth status on investments in children. And I think that how we think about adolescence is probably even more tragic. And in places where you see this notion that because we don't invest in our youth, we don't invest in our talent. And what we have found is that talent is equally distributed, but opportunity is not. The Johns Hopkins School of Education has done a study, not so much looking at disparities in terms of poor educational outcomes, but they looked at gifted youth. And what they found is in the city that is so harshly talked about in the United States, is that we have gifted young people all over that city, all over the city. And the reality is that they don't have the opportunities they need to meet their full educational and vocational attainment. And so what I've decided, and I decided a while ago, is that young people need heroes. They're looking for people to step into the fray. They're looking for scaffolding. They're looking for opportunities to lead. But there are times when young people need us to stand in the face of danger or difficulty to protect them, to advocate for them. Sometimes we just have to do it because we're the grown-ups in the world. And I love that that our poet laureate now for the United States is really, really very clear in that, there's always light if we are brave enough to see it, and if we're only brave enough to be it. And I think that the reality is that we have to do a better job for our young people, and that requires that adults to be braver. I give Johns Hopkins as an example of one of those people. I work in an institution, and in his letter to the trustees, he says that the indigent sick of the city with its environs, without regard to age, sex, age, or color, who require surgical or medical treatment, can be received into the hospital without inmates, and the poor of the city of state of all races who are stricken down by casualties shall be received in the hospital without charge. It's interesting because more recently it was discovered that Johns Hopkins owned slaves while he lived in Baltimore, and that was thought not to be true in the context of thinking about him as an anti-racist. Be that as it may, I think his last wish was still this. And twice he said that he wanted to do something that was anti-racist. And so I think that makes our charge, I think his history makes our charge a little more significant in Baltimore, which is the seat of the transatlantic slave trade. I don't think people realize that ships came to Baltimore and then slaves were transported south. I think it was an environment that was certainly one that it would be difficult to be anti-racist. And so perhaps he could only do this in death, but I think our charge in terms of how we have to work with the population in Baltimore and the things that we have to do to continue to affect change. I have worked in the American Academy of Pediatrics for over a decade now, and I think that it is inspiring. This is the old blueprint for children, how the next president before this president could do it. But it is the thing that I leaned into, in that the Academy says that we're going to address factors that make some children more vulnerable than others, such as race, ethnicity, religion, sexual orientation, gender identity, and disability, and that we must reform our broken immigration system. So this is before what is happening now in the Academy. But this was, you had to always have something in the Academy to lean on. Somebody has to have said it. And so for us, I think as the chair of the section on adolescent health, we thought a lot about how we can affect change for vulnerable young people, for young people of color in particular, around everything from gun violence to general health status. And we kept coming up, we put in resolutions to the annual leadership forum, and they would always be approved. I would defend them vociferously on the floor, but they never made it to the top 10. It was never in the top 10 of items. And so that meant the Academy really didn't adopt it for that year as a priority. And after doing some listening sessions and talks, particularly after the Freddie Gray case here in Baltimore and unrest here in the city, we did these talks on racism at PAS, at the American Academy of Pediatrics meetings, at the National Medical Association's meeting. And what we found that people said, we have to have some kind of policy, we have to change, we have to have guidelines, we have to have some strategy to deal with racism in pediatric practice. And our idea was to change bright futures, but they said there's no policy. And so if you want to change something in the Academy, you need to write a policy statement. So that's what we did. And I was able to partner. After getting it approved by the Academy, I was able to create a collaborative relationship with Jackie Duget and Danielle Dooley, and we created a writing group, and they took that first draft of the document and really helped me work through it and polish it. And so it's really, I think, a really collaborative work. But what's exciting is that last summer at the National Medical Association meeting, both Sally and Mark Monte, this powerful thing, but I heard it in another context, and they said we must dismantle racism at every individual institution. Systemic. And then Mark went on to say that we have always taken on these complex threats to children's health, and we don't flinch from this one. And I thought, well, wow. And then there's this tagline: racism harms the health of children's, teens, and families. And I found myself thinking, well, maybe things have changed. And then I saw that 168,000 people had downloaded the full text of that document. And I realized that of all the randomized controlled trials, of all the other studies that take me 5 and 10 years to complete, perhaps this is the document that is a defining piece of the thing that I can contribute, because it is something that may affect change for children. And the reason why we have to think about race is because it's not real, not really. It's a social construct. And if you look on the right, you can see these are the racial categories in the United States. Things that are purely biologically based or based in fact, they just don't change that much. Initially in the United States, racial categories were based on freedom, and they gradually transferred to what we see. And then they gradually transitioned to perhaps where people come from. I mean, there was even a point where how much you had of one of the things that you see became an identifier in the United States. And so these categories are really defined and based on how people wanted to organize society, and were driven by people in power. It was actually imported to the United States. We first see racial categorizations and defining of peoples as a part of the Spanish Inquisition, where people really wanted to suppress Jews in Europe. In Spain in particular, and because of the role in colonization, so we see that play out as we see people begin to migrate around the world, and certainly as the United States was colonized. But the challenge becomes that those things affect education, employment, wealth and income, criminal justice issues, and how children interface with those systems, and housing. And it drives access to care, and then subsequently the health and developmental outcomes for young people. The other reason is that I like to talk about it, whether or not it's a myth or it's real or it's a social construct or a biological construct, is because I think the data suggests that it is really a social construct. Francis Collins, the PI of the Human Genome Project, director at NIH, says race and ethnicity are poorly defined terms that serve as flawed surrogates for multiple environmental and genetic factors and disease causation, including ancestral geography, origins, socioeconomic status, education, access to care, and that research must move beyond these weak and imperfect proxy relationships to define more proximate factors that influence health. His early data really demonstrated that we are 99.9% the same. And the reality is that we are so focused on the 0.1% differences and the superficial things, the declines, the things that allowed us to survive different climates and spaces as people migrated around the world from our common ancestry, that those things aren't really the things that make us biologically different. And then the levels of racism, when you think about how does it play out, it really could be any ism. I happen to focus on race today. You could focus another day on homophobia. You could focus another day on religious discrimination. But today I'm going to focus on racism. And it can occur at 3 levels: institutional or structural. Those are things that are policies or laws, things that are part of our society that are sanctioned. Personally mediated. If you hurt somebody individually, you cause a kid gets bullied on the schoolyard because of one of those isms. That is personally mediated, as an example. And then internalized is when you see so much negativity about people like you that you begin to internalize it. People talk a lot about equity, equality, and justice. And so I just wanted to have a slide to just talk about sort of where I stand and sort of how I use those terms. So equality means everybody gets the same thing. And then equity is everyone gets what they need. And justice means that people get fair treatment, resulting in equitable opportunities. And then inclusion means everyone gets to participate. Oftentimes we think about equity as a part of a disability model. I think of these things where they have people of different heights trying to see over a ball field. Well, those people are all different. And I'm not saying that height is a disability. I'm just saying that they're showing something that suggests that people that their equity would be making sure that all people can see through the ball field. But justice is meaning that people can actually get to the ball field, that they could see regardless of whatever physical characteristics that they have. There should be no fence at all, I guess is basically my point, and that everyone gets to fully participate. And that is inclusion. And so when we think about the timeline of institutional or structural racism, I think it's deep in our roots. I think when we think about equity, we just look at the tree. And for a long time, we focused on equality, but that resulted in separate but equal and Jim Crow laws in the United States. But all of those things are really deep within our roots. It starts in probably 1619 on mainland United States, but 1501 in the Americas, so chattel slavery, and went on to 1865. We have the Naturalization Act in 1790, only Europeans could become U.S. citizens. 1830, Indian Removal Act, all Native Americans had to move west of the Mississippi into harsh climates. Over 3,000 lives were lost in initial moves. 1860, the Homestead Act, meaning once they moved and they could get their land taken for others to settle it for little or no cost. Jim Crow laws really facilitate separate but equal, and activities were not at all equal, impacted people's ability to participate in civic engagement in society. Mexican repatriation in 1929 to 1936, Mexican Americans were repatriated to Mexico, which actually was very difficult period, and Mexican Americans really fought back against that. And you see the emergence of the Chicano movement over time. USADA loan discrimination. Most African American folks in the South in particular were farmers. And if you can't borrow money against your land at a reasonable rate and then grow your crops and then pay it back, then you're not able to function as a farmer in the system. And so many farmers in the South lost their farms because they weren't able to participate in the loan programs. The Social Security Act and the Wagner Act, which would allowed for the formation of unions, that domestics and farmers were not allowed to participate in that. And so you have a generation of individuals, particularly domestics that were not able to receive Social Security benefits. Federal Housing Administration was actively engaged in segregating America and redlining communities. 1942, you have the internment of Japanese Americans. 1944, the Services Community Justice Act. You would think that after someone fights in a world war overseas, that they would be able to come back and access housing loans and the opportunity to attend college, but they followed Jim Crow laws and things were segregated. And so individuals did not get access to the benefits that they deserved. And so you see these things sort of pile up over time, and people say, well, why don't you just pull yourself up by your bootstraps? But people consistently don't have boots, and that becomes a challenge to doing that. I'll just show you an example of the redlining map in Baltimore. And you can see here, these areas in red are considered the areas that you don't want. But it's interesting, those are the areas of disparity. It probably is this whole area that you see here and this whole area now. This is East Baltimore. This is where I work. And this is where you see the greatest disparities in the city. And it follows these maps over time. And so, and the racial wealth gap is probably the clearest legacy of discrimination of housing markets in the United States. What you see now is if you see the average and median household wealth in the United States by race, you can see that white families generally have an average of household wealth that is really striking in comparison. We'll just look at the median here. You can see that the median for whites is $171,000, and for Blacks, it's around $17,600. And I think that's a real challenge in terms of how we look at society. If we look at the average, it's even more stark, from almost $1 million to just $138,200. And so this is something to think about. And people say, well, why does that matter? And I think studying and working hard is not enough. Folks have done research and have demonstrated, at Duke have demonstrated that there are no equalizers for wealth, not employment, not education, not family income. And it means that you have this absence of wealth to draw upon in a crisis. A great example from our group is we had a young lady a number of years back who had a wonderful family, has suffered a lot of hardship, and who had a full scholarship to college, full scholarship, housing, everything. The only thing that they had to pay was a $500 matriculation fee, and the family didn't have that. I think we couldn't believe that a young person who had worked so hard, who was so brilliant and wonderful, who had all this loss and still overcame all of that, only needed $500 to access her future, and her family didn't have it. I mean, it was easy for us. I think we pulled the money together in less than an hour. But I think that there's this notion that not every person has the kind of group that we have, or has access to people who are doctors who can pull that money together to support them to make their transition. She even gave us, I mean, we set it up so that she could earn it. And that was the other challenge. It was a gift, but it was an opportunity for us to allow her to build on gifts and talents that she already had, which made it even, I think, more significant for her. And it's not just African-American populations. I mentioned Native American populations earlier, but and the Indian Removal and Homestead Acts, but then there's the Native American boarding schools, the consistent underfunding of the Indian Health Service, the environmental justice issues that are moving forward through Native American communities. Then there's the pandemic support related to COVID-19, people and their access to clinical services. I'm just so proud of one of my former medical students told me that she took a job sight unseen in emergency medicine to move to the Indian Health Service in the middle of a pandemic. And I think about education, how people live out in communities that may be remote, and how they're going to access the internet during this period where we're all having to stay home and to ensure that our children get education. Then their voting rights, that same issue applies, that their rights to participate and to be involved civically are undermined because their mail carrier is not going to drive to all those remote regions, but rather to send their mail post office box. And then racial appropriation is an ongoing issue, but I think many organizations are now trying to address that. And then there's this notion where people say, well, this is new. We didn't realize that racism had an impact on health. This data, it's so new from this policy statement, but it's not new. I show you this systematic review just as an example. I'm not going to belabor all of the data that's out there, but racism is consistently associated with poor mental health, including depression, anxiety, and psychological distress, poor general health, and poor physical health. I show you the slides not so that you can read all the articles, but this is just one page of the reports from this systematic review and all of the many articles that have been written about the impact of racism on health. We just chose to ignore it and to continue to move about in society. And so we have to think about how we're going to really transform what we know to be true, but it's well documented in the literature. And I think it's important to me because the challenge becomes, it started to come to a place where there's a breaking point. And I think one of the things that we're seeing in certainly African-American communities is that traditionally people thought that African-American youth, for example, did not commit suicide. Historically, I think epidemiologically that was the case. But I think now that is no longer true. When I think about when we look at the state of Maryland, young people in Baltimore who are disproportionately African-American have the highest rates of suicide in the state of Maryland. The other thing we have to think about is, how does this affect other children? How does it affect white children? I don't think we think about them a lot. And I think of a story that a mother told about her daughter whose best friend was Black, and they were riding on the school bus and someone called her best friend a bad name. And she came home and she told her mother, she was upset about it. And the mother said, well, what did you do? And she said, I just sat there and hurt with her. And I think there's this notion of other children being hurt by racism as bystanders. There's a study by Jansen and colleagues that really demonstrates its impact, its lasting impact on people over time. And so they asked young adults to recall incidents from childhood where they saw trauma, they saw abuse, they saw people bullied, just to recall those incidents, and they had them hooked up into the lab. And what they found was that young people who had just remembering those incidences from their past, generated a physiological response that was akin to a first responder to a natural disaster like an earthquake in San Francisco. And so it's really important that we remember that it doesn't just affect the children of color, it affects all children who are operating in those spaces with them. For us to think back and to think that children actually in past generations used to attend lynchings to watch people murdered as a part of a social event. I mean, those things, there's a generation of grownups in our societies who are still carrying that with them as a part of their sort of their historical memory. And people say, well, how does it work in children? It can't really be an issue for children. And I tend to think about the work of Jane Elliott, who was a third grade teacher in Iowa, who wanted to teach her classroom of all white students about racism after Martin Luther King died. So she divided the class by eye color to brown-eyed children versus the blue-eyed children. And she decided that the blue-eyed children the first day would get special treatment. They could line up for recess first. They could go to lunch first. If they got something right, of course, it was because they had blue eyes. If they missed anything, that was ignored. As opposed to the brown-eyed children who were treated differently. They got to line up last because of their blue eyes. They got to go out to recess less, so they got less time. And if they got something wrong, it was, of course, because they had blue eyes. And by the end of the day, what she found is that they were just demoralized. And the brown-eyed children and the blue-eyed children felt this sense of superiority. And these were children who were all friends the day before, for the most part, and how they changed. And then the next day she reversed it. And the brown-eyed children were the superior children. And the blue-eyed children were outraged because they realized the injustice of it all. And so I think that the challenge becomes if a group of children who are privileged in general at that time certainly could be impacted in just one day of being discriminated against. Imagine what it's like for children to experience that every day over generations. And there's data to support its impact, for example, on African-American children. I refer to the work of doctors Kenneth and Mamie Clark, who did the original doll test. And the work was used in the case of Brown versus the Board of Education to demonstrate the harmful effects of segregation on children. But a young person, Kiri Davis, when she was a teenager, developed this film where she actually replicated the doll test with a group of children in New York. And it was strikingly similar to the findings that Drs. Clark found in their research. And I would encourage you to watch it if you have not seen it, but it is a really powerful portrayal where you see internalized racism at play. They consistently chose the white doll as the good doll, as the nice doll, and the one that they wanted to have. And then when asked about the black doll, they characterized it all these negative things, but then they also identified that the doll is the one that looked like them. It's a very powerful thing to watch. And what we see is that social isolation and stigmatization that children of color often experience is troubling. And this work by Liz Goodman, one of my colleagues in Adolescent Health, really demonstrates that it spills over into children of Black children in particular, of educated parents were more likely to experience mental health and symptoms like depression. It's in part because the environments that we expect them to navigate without us. There's some security in spaces in which there are other people who are like them. It's as the work of Beverly Tatum's, her book, Why Are All the Black Children Sitting in the Cafeteria Together, and other conversations about race, is that during critical periods of identity development, if you don't see someone like you or engage someone like you and have those positive experiences, it can also shape your development. And then there are other groups. This is something that I came across in Time magazine, where they interviewed Asian Americans during this pandemic and the need, and they reflect on racism and inequality. I think that we don't talk about this very often, but I think it's come to light for Asian American populations. But there is research that has been out for some time, and it talks about the experiences of discrimination, for example, amongst Chinese adolescents and the consequences for social, emotional development and academic development. So I would say that that young people who carry any type of stigma associated with, or any type of experiences where their identity is a source for discrimination can have adverse outcomes. And I think that we have to be more thoughtful about how we manage that, because there are sparks that young people need for better outcomes to move into their adulthood thriving. They have to be adaptable and flexible, have a sense of purpose, be hopeful for and optimistic for the future, not have worries or concerns, have life satisfaction, feel happy and energized, but they also have to have a strong sense of their ethnic identity. Maternal discrimination, I'll just mention it here because mothers are a critical role in ensuring happy futures for their children. Both parents are, but this research I found to be particularly profound because we also have some issues around maternal mortality particularly in the African-American community. And when they talk to women in qualitative research, they found that across the life course that women experienced racism, and that their childhood events were the most salient and enduring, that they also experienced it in the present directly and vicariously through their child at all levels, across life domains, that their responses could be active or passive depending on the situation, but they constantly found themselves anticipating threats for themselves or their children. And then from a quantitative perspective, they have done studies across the nation, and they've looked at telomere length, the ends of the caps of the chromosomes, and they found that African-American women were 7.5 years older than their white peers due to stress. And so it's not surprising that we see the outcomes we see in infant mortality particularly amongst non-Hispanic Black infants and their moms and their maternal outcomes. And now we're seeing a group that was thought to have some protection, this Latino Paradox, disappearing. Recent studies found that U.S. immigration enforcement policies are impacting the health of Latina mothers, both those that are foreign-born and foreign and U.S. born. So this whole notion of weathering, of having this process, it's occur in Latina mothers is really changing. And so we now have to be more thoughtful about how we're going to care for their mothers, but also their children. So what can pediatric practitioners do? We have to optimize pediatric and public health practice. We have to optimize the workforce development and professional education. We have to optimize systems through community engagement, advocacy, and public policy. And we have to optimize our research activities. There are tools available for public health practice. I love referring to other items because I think that there is information and out there that can help us guide our next steps and direction. As an example, from a public health perspective, how does that interface with the clinical environment in Baltimore for us? We have significant transportation disparities in our city. It's not clear why they gave the money back to the federal government that would have created an amazing subway system in Baltimore that would allow people greater access to the things that they need. But that was a real issue for our patients in terms of how they're going to get to care. And so we created a relationship with Lyft, and we were able to a commercial ride sharing service, and we were able to really get patients into their well care. And this so far demonstrates that we have wide geographic dispersion of patients around our practice. And we were worried about its impact on our ability to get patients in for primary care. And that may be true since people are tending to come for acute care. Certainly initially, but we haven't seen substantial differences in the pre and post-COVID rates. But it's an example of how we can use research to deliver better care, to think about what needs to happen in our community to get young people into care, and to impact health disparities. I would also say we have to identify our blind spots. Not all racial differences is explained by poverty, and there are stresses of living and working in a world where you're continually demeaned in small ways and large that have an effect on the body. I show this picture. This is me as a fellow when we lived in Boston. One of the most profound moments of my experience there out in the community was the day that a police officer walked up to my husband as we were getting into our car in front of our home in one of the wealthiest communities in America. for our overpaid, in front of our overpaid priced apartment, and said that my PhD having college professor, just status husband, and a young doctor that he fit the description of a suspect. And so that no matter what we're doing, they're not any safe spaces, not even at home. And it changed how we thought about the city and whether or not we could stay there, in part because I think we weren't seen as accepted there. And I will say that it's important for us when we're in spaces with young people that we see them. And I think this year I had a moment myself where I was worried that I might not be able to see them anymore because I thought that that was my gift, that I might miss something. But I in my first day back after being away from being in our clinic, I was just thrown in there. Every kid had grief, every kid had something major. And the resident wrote me this email after that day, and she said, I just want to thank you for the conversation you had with the patient today in clinic. You talked about her future and her potential, essentially about her whole health, rather than just her physical and mental health, where our work often stops. Thank you for modeling that we can do more, for letting me witness it. I'm grateful to have examples of others who show that there's something bigger we can build. You made my month. So for me, it was very powerful that I can still see young people. So we have to stop saying things like, I don't see color. That's just not, because it's not true on its face. We see the differences in all of us. We have to see it and for it to not matter so we can focus on those other things beneath the surfaces. And then we have to train the next generation how to find that in their own gifts. The AAP has done a great job of doing that, I have to say, in response to it's been very responsive to the policy statement and its uptake by our members. This anti-discrimination policy that's now in the bylaws, in addition to this reconciliation for some early African-American pediatricians who were denied membership based on really superficial kinds of reasons, like we don't want to have dinner with them, really was an open process that the Academy has dealt with. And I think for me as a member, that has been a very powerful experience. People will often say, well, what can I do? And it's interesting that this meme of Bernie Sanders is going around. I'm just going to remember Bernie Sanders this way. He sat in the fray when it was time to fight for equity, for justice. And so I probably would say for me, this is a more powerful meme than of him sitting at the inauguration with this woman. Other people say, well, what can I do in my everyday life? And so this is an email that I received from a colleague who's not in my close group, but who I know well. And the day after the insurrection in DC, she says, hi, Maria, if I can ever use my unearned privileges to give you some of your hard-fought ones or to help keep you and your kids safe, please know what an honor it would be. So when someone steps out of their space to say, I see you, I've got your back, you just let me know. That's something that you can do. Because I think people say, well, I can't go out of my space. This is her stepping out of her space. And it was a very powerful day for me, for an email for me to get from someone the day after that occurred. We also have to be prepared to talk to young people about it. We have to help them read it, name it, oppose it, and replace it. We can't expect them to do it by themselves. Sometimes that means we have to, again, step into that space. Is it racism or is it something else? Are you behaving badly in school or is it racism? And then we have to, or are you, is it some other reason that you may be discriminated against? Is it your sexuality or some area of intersectionality? But we have to help them process it. And not talking about racism or race because it's uncomfortable means that we don't move into those spaces of healing and support, or into spaces of justice with them. We have to optimize workforce development and professional education and to really advocate for policies and programs that are designed to address implicit biases, improve healthcare quality. And that may mean diversifying our workforce and providing ongoing professional education. Essentially, we have to train the next generation to be and do better. We spend a lot of time making sure everyone has their CPR certification, their PAL certification, in adult systems, their ACLS certifications, that people can resuscitate babies in the NICU. We work very hard to ensure those things are in place because we consider it important for quality of care. It's a life-saving measure. The reality, though, is that if we can't communicate with patients and families, we won't learn what's wrong with them. We won't learn how to help them. And so at Hopkins, one of the things that we have done is we have set up a system where we can actually have young people experience simulation in the same space that they do the simulation for CPR. They can also learn cultural communication and have an opportunity to practice it. And what we found is in these scenarios, in this one, they just have to get the parent to trust them enough to leave. It's a basic adolescent medicine skill that every pediatrician should be able to talk to a young person without their parent for a few minutes. The other one was of a case of a young mother who's Spanish speaking only, who needed to understand why her baby, her newborn with fever, needed to have a complete sepsis workup and to explain the procedures. And that was a trickier one. And they had to use the interpreter. So even if the person spoke Spanish, they had to use the interpreter. And those kinds of challenges allow people the opportunity to practice doing that and to get feedback on it in a safe space until they really have to do it, for example, at a child that they've just resuscitated. So we have to optimize the systems through community engagement, advocacy, and public policy. And that is around education policy, alternative strategies to school and community policing, which I can do an entire lecture on, incarceration for nonviolent youth behaviors, improved public policies around disease control, designing innovative strategies to mitigate the impacts of racism on children and adolescents. I think these are all things that we have to do. But essentially what I'm asking you to do, again, is to become more powerful on behalf of adolescents. I need you to become heroes. And I never ask people to do things that I'm not willing to do myself. I will testify before the school board. I will testify at congressional briefings. I will testify to ensure that people are prepared to go and testify for their briefings. I will write to our newspaper. I will write to any newspaper if it's an issue that is moving me. So I'm not asking people to do something that I'm not willing to do, but I think unless we're all doing these things, then we will not be able to actually affect change. We also have to continue to talk about it in public spaces. And so this is a recent event that we had in October where we actually talked with the police. We viewed the film Charm City, which is really mostly about police interaction in Baltimore. And then we had a discussion about it. Brandon Scott is now a new mayor of Baltimore, but was city council president at the time. And so we really had an opportunity with the police present, with community leaders, and with young people to engage around how policing in Baltimore has the potential to undermine health and well-being of young people. But at the same time, as a city with high levels of crime, how we have to have police presence and how we value it. So in conclusion, racism is a social determinant of health that impacts the emotional, physical, and health of children, adolescents, adults, and families. Youth-serving professionals play a vital role in preventing and mitigating the impacts of racism through examining their personal biases, clinical and public health practice, advocacy research, and community-based engagement. But there are daily policy threats to the well-being of children in pediatric practice in school and in communities. I think COVID-19 has really uncovered some of the flaws in the US public health priorities and systems and the remnants of historic and current racism. The AAP policy statement on racism and its impact on child and adolescent health, it really provides just recommendations to help health professionals address racism in practice. But really now it's time for us to do the work at the local level. I will say that doing cultural competency trainings and doing diversity, equity, and inclusion work really requires that you have a strong team of people that have your back. I'm just so grateful to all the people on this slide for their efforts to allow me to take leaps into that space. I'm happy to take questions if you have any.
Thank you, Dr. Trent, so much once again for an information-filled, impactful, powerful discussion. And we do have some questions in the chat. And the first one is from Dr. Diego Chavez-Henigal. Thank you very much for an amazing presentation. Could you please elaborate in how the Hispanic Latino paradox is disappearing / reverse. What can we do as pediatricians to support our Latino communities, and in particular, their strengths and social and health values? Thanks.
So it's an important question, but I think the U.S. immigration policies have dramatically affected the stress level for Latino mothers and their ability to not just navigate the health system, but navigate community spaces. Um, and I think it's one thing when we think about individuals who may be undocumented and how they have to navigate the country with particular care, certainly over the last 4 years. That has been a real reality for people in terms of safety, in terms of being separated from their children. These are things that I think mothers hold dear. Oftentimes, these are not necessarily just first-time moms. These are mothers with other children. So I think those are real stressors for women in the Latino community. I think the other issue is about this sort of mental health impacts on women who may not be immigrants, and how society has shifted in terms of how they think about those women and how they move through society. And so I think it's a similar kind of pressure and stress that we see women in the African-American community experiencing, and those have been shown to have direct impacts on maternal mortality and on infant mortality. So what I'll say is the things that we can do is that we can address as a society, we have to reform immigration. That's a particular issue. I think we have to have, but if we have to think about what our practices can do, we have to use culturally and linguistically appropriate services. We have to ensure that people feel welcome coming to our environment. Healthcare facilities are actually supposed to be safe spaces for patients and families, but I don't know that people have always felt that way. So we have to make sure that women get the prenatal care that they need, and that their children, their infants receive certainly the follow-up care that they need. But I think that we have to just do better as a society in terms of acceptance and in terms of management. I think that when we see there's a generation of children that are just going to be lost, there's no way that that's not affecting how people see themselves in American society. And I think we do have to do some work to measure that stress. I think that when we think about the work that has been done in this area, I think we have to do more work, but I'm not sure how easy it will be for us to actually engage these women in scientific research, because they may not feel safe to do that either. So I think that there's a ton of work for us to do in that area. I think people are hoping that as we have a swing in society, perhaps with a new government, that we might be able to make some shifts in terms of supporting the Latin community and making sure that people have not just access to care, but that the shifts in society will ensure that people feel safe. I hope that's helpful.
Very helpful. Thank you, Maria. I'm just checking on the time. One thought that occurred to me, if I might ask you about, and this is obviously more on the OBGYN side than adolescent medicine side, but in thinking about the disparities in terms of infant mortality and maternal mortality for African-American women around childbirth, and the research on telomeres, and the issue of being, 7 years essentially older based on stress, whether we need to start thinking about some of our Black pregnant moms need to maybe be in a higher risk category from the outset, right? Do we need to start adapting that research into our practice? Meaning, as someone who was an older mom with my first child, I was treated somewhat differently during my pregnancy. And I'm wondering, from an outcome point of view, if you think it's time for us to have we gotten to that point in the research where we need to take that into account when we're dealing with women of color who are pregnant, that actually, while they may be, relatively young, they actually are older, and maybe they should be treated from an obstetrical point of view as a higher risk patient from the very beginning.
It's possible. So the same woman that did the research that I showed you on the Latino Paradox has also done a lot of work on the weathering hypothesis. And Geronimus really demonstrates that there may be some benefits to actually earlier childbearing for African-American women. It's the exact point that you raised. it's interesting because we debated in the adolescent sexual reproductive health course I teach at the School of Public Health, like what are the true benefits, what are the effects on adolescent development of early motherhood, and what are some of the trajectories. And one of my longtime mentors, Lori Zabian, actually demonstrated for young women in Baltimore, they actually rebound after they have children. So I think it's an important point, but I don't think, I think my justice piece is that adolescent and young adult women should not have to have a baby before they're ready, knowing that they want one, because it's going to be so dangerous for them to have one when it was truly destined to be, when they had finished becoming their complete selves. I think that's the real, that's the sort of justice piece that I think we have to move towards in terms of adolescent and young adult health. That they get to experience young adulthood without this worry. Our data do demonstrate that adolescents and young adults feel very strongly across gender that being a parent in the future is somewhat or very important to them. And so our ability to create improved health status for adolescents in the United States, I think globally, I think across groups is going to be an important thing to ensure that that happens.
Very much, Maria. We'd like folks to log on to the meet and greet where we'll have more time to talk with Dr. Trent. And want to thank you once again, Dr. Trent, for an amazing presentation.
Thank you all for having me this morning.
See you in the meet and greet. Just click on to the next link.
Okay, thank you.